We should start today's AHN Nephrology Education webinar. My name is Gina Makwabe. I'm the consultant physician and nephrologist working in Tanzania with Africa Healthcare Network. I would like to welcome you all to today's AHN Nephrology Education webinar. And today's series number 106, but the second series this year. We started last week. So today is the second session for this year. Today's topic is very interesting because we are discussing diabetes, which is the leading cause of CKD worldwide. And today's topic is diabetes in the lean in developing countries, the differential diagnosis and original insight into the pathogenesis. It's a great honor today to introduce our today's speaker, who is Professor Nihal Thomas, who is a senior professor, Department of Diabetes and Endocrinology and Metabolism from the Christian Medical College, Vellore in India. His former portfolio includes the Vice Principal, Research, and Associate Director and Deputy Medical Superintendent at CMC, Vellore. He has more than 330 index publications, several chapters, and 3 books. His area of interest involves the pathogenesis of diabetes in India and general endocrinology. He initiated projects to train medical and paramedical staff from 200 rural hospitals for diabetes. The CV of Professor Nihal is very long, but in summary, that's what I could summarize. And therefore, I would like to welcome you, Professor Nihal. It's a great honor and pleasure. And we are all so excited to listen to you. You are warmly welcome, Professor.
Thank you so much. And it's an absolute privilege to be here. Thank you for inviting me to give a talk at your network. I'd like to specifically thank you, Dr. David, Dr. Gina, Dr. Saksham, and all the others, and particularly Dr. Lloyd, whom I've known for more than 3 decades now. Interestingly, Lloyd was doing his nephrology training over here in Vellore when I was doing my internal medicine training. And in fact, at many points of time during management of cases, we crossed our paths, and I could say it was an absolute pleasure. So what I thought I'd cover today is looking at diabetes and the lean in developing countries. I know that this is a significant problem, not just in South Asia and India, but also in Africa. I have a lot of good friends in different parts of Africa, and particularly in East Africa. I've had collaborators who have visited Tanzania and Uganda, and I do know that lean diabetes exists. But this would be rather a non-specific term, and we need to zone in and try and figure out what we are dealing with. So they say it's genes, not the blue variety. Environments have a role, and the lack of satiety. Epigenetics, low birth weight problems for poor, dwindling secretion, and resistance for sure. If you look at the WHO classification for diabetes, it categorizes them into type 1, type 2, and then you have the hybrid forms which have evolved and been described, particularly in the 2019 edition of the WHO classification, and the other specific types. And if you look on a day-to-day basis, and you're focusing on diabetes in particular, you will see most of these conditions. It is not the rare or the exotic. For example, if you look at the classification, you talk about monogenic defects of beta cell function or monogenic defects in insulin action. These problems are there, and they in fact encompass about 5% of the problems that you see. How do you sift the wheat from the chaff? How do you differentiate these different forms of diabetes amongst the milieu of a large volume of type 2 diabetes that you might be seeing, and of course type 1 diabetes, which you presume you're seeing a lot of because they need insulin or they have ketoacidosis. So I'm going to go through 7 clinical scenarios commonly misdiagnosed or rather diagnosed as type 1 diabetes. And I would like to highlight the causes for a lean person with diabetes. When I say lean, I'm being very categorical and saying BMI, body mass index of less than 20 kg per meter squared. So let's not be nebulous over here. In South Asia, when we say somebody is overweight, we mean a BMI of more than 23. If you go by the WHO classification of overweight, it means more than 25, and I do presume that is what is being followed in Africa. But when we say lean, we mean lean to malnourished. Lean means less than 20 kg per meter squared. Malnourished means less than 18.5 kilogram per meter squared. And these are the potential causes, and I shall take you through examples of each of these cases. Fibrocalcic pancreatic diabetes, monogenic disorders of beta cell secretion, affectionately called MODY, or maturity onset diabetes of the young, but there's a lot more than just MODY. Lipodystrophy, Wolfram's-like syndrome, HIP lipodystrophy, and then this condition which was erased from the WHO classification, protein deficient or malnutrition modulated diabetes. So here is a 37-year-old gentleman who was known to be hyperthyroid for 2 years on antithyroid medications, had diabetes for 2 years, osmotic symptoms, started an oral antidiabetic agent, responded very well initially, but in about 9 to 12 months was changed to insulin. He was on 4 oral antidiabetic agents. He was started on metformin, glibenclamide, pioglitazone, and subsequently the DPP4 inhibitors. And on max dose of that, then subsequently needed insulin. Weight loss, increase in appetite, and osmotic symptoms, and there was no diabetic ketoacidosis or any family history. On examination, he was lean, had a BMI of 16.7. He had a palpable goiter, and at that time, his systemic examination was normal. So, because of his loss of weight, we looked for other causes. We also looked at the pancreas, and the imaging of the abdomen was normal. One of the tests which we do to diagnose autoimmune diabetes or type 1 diabetes is a GAD antibody. There are, of course, a host of antibodies available on the international scene. In India, in Vellore, we're using just the GAD and the IA2 because we believe it covers about 95% of what you need to diagnose in autoimmune diabetes. So when it's less than 30 years of age, you call it type 1. You can get autoimmune disease more than 30 years. That's called slowly evolving immune-mediated diabetes in adults. And that condition was initially called LADA, or latent autoimmune diabetes in adults. So the C-peptides were low and the GAD antibody is positive, indicating that this is definitely an autoimmune diabetes. The patient also has hyperthyroidism, and the TRAB was positive, indicating concomitant Graves' disease. So here we have slowly evolving immune-related diabetes as a diagnosis, autoimmune diabetes in an older person. Now, this should not be missed. You can pick up this disease even in 50-year-olds or even in 60-year-olds occasionally. And therefore, when you have a lean person who does not respond to OADs, think of this particular condition. It was called, of course, from a colloquial perspective, type 1.5 diabetes. But what are the characteristics of the disease? More than 30 years of age, other autoimmune features may or may not be present. They are lean. The C-peptides will be categorically low once they cannot be managed with oral antidiabetic agents. Autoantibodies, if you have the facility, please do them, and they are positive in about 80% of cases. Rule out pancreatic pathology, do an ultrasound of the abdomen, and of course, you need to start an insulin. How do they differ from classical type 1? They tend to be a little insulin resistant more than type 1. And usually only a single antibody is positive. If you have the battery of antibodies, only a single antibody is positive. So they need to be managed with insulin. You need to give them basal bolus insulin like how you manage type 1 diabetes. So a split mix regimen. Scenario 2, 33-year-old gentleman, laborer, upper abdominal pain radiating to the back since 1 year, loss of weight of 54 to 44 kgs over 6 months, normal bowel habits, history of diabetes over 3 years and oral antidiabetic agents. No history of ketoacidosis, no history of smoking or alcohol. Once again, lean, BMI of 20.5 kilogram per meter squared. Otherwise, no nutrition deficiencies, mild epigastric tenderness on palpation of the abdomen. So what the primary physician initially did is that he took a chest X-ray to look for other causes for weight loss, like tuberculosis. But what he did see was this large, chunky calcification over here in the area of the pancreas, in the L12, the T12L1 region, indicating that it was pancreatic calcification. And His stool elastase, which is a measure of malabsorption, was very low. We used to initially do stool fat absorption. That is a much better test, but it's cumbersome where you collect the stool over 3 days and then measure the fat in that. Now we do the stool elastase. CT abdomen showed evidence of duct dilatation and chunky large calcification, atrophic pancreas indicative of fibrocalcific pancreatic diabetes. And the MRI, in fact, showed a mass in the head of the pancreas indicating the possibility of concomitant malignancy. And his marker for pancreatic cancer was positive. Now, endoscopic ultrasound was done, and on biopsy confirmed the diagnosis of pancreatic cancer. Now, this particular condition was initially found in a southern state of Kerala at one point in time as very, very common, way back about 40 years. But the proportion of disease in Kerala has declined. But it is still present in the state where I work in Tamil Nadu and other parts of India. If you look at the initial prevalence maps which have been drawn, and I will show you one, this disorder does exist in East Africa in addition. So the salient features, second or third decade onset of diabetes after the age of 15, usually between the ages of 15 and as late as 35 years of age, 70% male, no history of alcohol ingestion, lean BMI, no features of insulin resistance. C-peptides are low, and an ultrasound abdomen may show a positive atrophic pancreas, duct dilatation. But of course, ultrasounds may not be sensitive, and it depends on the operator. So a CT is always a much better tool. If they cross the age of 50, there's a 40% chance of developing pancreatic cancer. So you look at this map, which was published way back in the late 1970s in Diabetes Care, and there are prevalence in reports from East Africa, and I believe this map seems to cover what looks like Tanzania and perhaps Uganda and maybe Rwanda as well, in addition, and going into the Congo. So it was first reported in Indonesia. The earliest cases in India were reported in the late 1950s and 60s, and we still see it right across the board. We don't know what the environmental factors. There are certain genes, the SPINK1 mutation, which is present in about 30 to 35% of these cases. But there is it's a double hit hypothesis. So there is probably some environmental factor which we still don't know what it is. Tapioca was proposed at one time, cassava that is, but we know that's probably not true anymore. So it should be looked for. We have done some original work in this area. We have found that osteoporosis is common, and it's related more to, they do have vitamin D deficiency, but it's more related to the degree of fat malabsorption than vitamin D deficiency. Autonomic dysfunction is common, can exacerbate the diarrhea. 65% of them have autonomic dysfunction, probably due to concomitant micronutrient deficiency as well as poor control of diabetes. Energy expenditure is very high, and I'll tell you the reason for this. It's actually out of proportion because they have malabsorption of fat, they have poor control of sugars, that leads to weight loss. But in addition, they burn a lot of their calories and energy, and they end up being even thinner. So you have to give them a high calorie diet in excess of 2,500 to 3,000 calories, more than an average diabetic. And they have multiple micronutrient deficiencies which coincide. We should be very careful, especially with the stool elastase. It's got sensitivity, but its specificity is not that great. Borderline low stool elastase levels can actually occur in type 2 diabetes, which indicates if you have diabetes for more than 10 years, even without obvious autonomic dysfunction, they can have some fat malabsorption. This was a study which we looked at, and our primary thing is to look at autonomic dysfunction because they had a lot of severe hypoglycemic episodes when they presented. And we compared patients with fibrocalcific pancreatic diabetes, what we call FCPD, with those who did not have fibrocalcific pancreatic diabetes, and also with an arm with patients who had hypoglycemia or without hypoglycemia. And we looked at them and we looked at the autonomic function test and we measured the glucagon levels. The peculiar thing in fibrocalcific pancreatic diabetes, despite the atrophic pancreas, and you expect not just the beta cells but the alpha cells to be damaged, was that even the glucagon levels were paradoxically high. You have a fibrotic pancreas, why should that happen? I'll come to the reason later. But the glucagon levels were elevated, and they were lower in those who had hypoglycemia when compared to those who did not have hypoglycemia. But in any case, they were much higher than what is seen in the control group in terms of their glucagon levels. So the glucagon, when it was elevated, actually protected those who did not have hypoglycemia from developing hypoglycemia. You can see over here quite clearly, and a lot of the indices of hypoglycemia unawareness showed parallelisms with the lack of glucagon in these patients. When you look at a population of patients in a secondary care or primary care center, what should you think about when you see a lean patient? If it's lean, yes, still the most common cause is type 1. But in our population, when you had lean patients, the second most common cause, and this is not in where I am in South India, but in the northern part, we collaborated and we did the genetic test for them. 15% of them had fibrocalcic pancreatic diabetes. Now, obesity is also becoming a problem in children in India. And therefore, in that particular population, quite a few young people, less than 25 to 30 years of age, had type 2 diabetes as well. But they have high C-peptide levels in the initial phase for the first 5 or 6 years, which none of the other conditions have. And of course, the other important cause in this holistic study was beta cell dysfunction, where you have intermediate C-peptide levels, the postprandial C-peptide levels are suboptimal, but if you give a sulfonylurea in some kinds, the C-peptide levels rise after giving the sulfonylurea. So fibrocalcic pancreatic diabetes is important. It should be looked in your population. When you have a lean patient with diabetes, please do an imaging of the abdomen to look at the pancreas very specifically. 16-year-old girl diagnosed to have diabetes during routine testing on thrice daily insulin, had a history of renal stones. And in fact, her first problem was that of chronic renal failure. She came with CKD stage 3 initially to her physician, and she had a previous DJ setting and lithotripsy. Now, she also had cyclical low abdominal pain every month, but had not attained menarche. No steatorrhea, mother was pre-diabetic, and paternal aunt was diabetic. So her BMI was 21.2 kgs per meter squared, and she did have development of her breasts and pubic hair indicating adequate pubertal growth and development. You can see over here that the an imaging was done. We did an MRI, and it showed a biconate uterus, and it also showed an imperforate hymen. In addition to that, you can see that on the MRI, the pancreas is atrophic and small, but not with no calcification indeed at the same time. So it's an atrophic pancreas and a biconate uterus. So we thought of a potential genetic cause, and we went ahead and subsequently did genetic testing in our lab. We do the next generation sequencing in our own lab, and we do the bioinformatics, and we found that there was a MODY5, maturity onset diabetes of the young 5 with a hepatic nucleotrophic factor 1 beta cause. So they can present with any of these anomalies, and in males can have an absent vas deferens. They can have pancreatic atrophy, which can be gross, but sometimes maybe just borderline as well. So the phenotypic presentation will be highly varied. Some of them can be managed with oral anti-diabetic agents. Other patients need insulin at an early phase. So here's another one, 16-year-old boy, grossly lean, high sugars, came with ketoacidosis, put on basal bolus insulin as the primary presentation. C-peptides were low. He had malabsorption, which was mild. And you can see the grossly low C-peptide levels, and the antibodies were negative. So we did an imaging of the abdomen. It showed borderline atrophy of the pancreas, not gross like the previous patient, but the severity of diabetes was much more. And once again, we have a MODY5 mutation over here. So you can see the phenotypic difference in presentation of this particular condition. How does this differ from fibrocalcic pancreatic diabetes? Even though there may be atrophy, there is no duct dilatation and there is no calcification in pancreas. 29-year-old lady diagnosed to have diabetes in the first pregnancy after 5 years, increased frequency of stools, was diagnosed as calcific pancreatitis elsewhere, had a low stool elastase with malabsorption. Now, what you can see over here is the pancreas is atrophied, but there's also a replacement with fat. That's a prominent splenic vein that you can also see over there. And a few calcifications, but not very prominent, not typical of fibrocalcic pancreatic diabetes. Because of the fat replacement, we once again thought of another genetic cause. And This is lipomatosis, and we found that a different form of mutation was present. This is a carboxyethyl lipase mutation, another form of monogenic diabetes, this slide is not taken from this particular patient, but if you were to do a pancreatic biopsy, you'd find these findings of PS positivity in the tissue. So we have actually done a lot of work in monogenic diabetes, and this is our first publication from South Asia using next generation sequencing, and definitely the first one from India, where we looked at the causes of monogenic diabetes. Just briefly, there are 14 types of so-called MODY, or maturity onset diabetes of the young. And the types in the Western population include the glucokinase mutations, HNF4 alpha and 1 alpha, that is MODY 1, 2, and 3. Now, in our Indian population, we found the pattern is quite different. We do have MODY 1 and 3. MODY 2 or glucokinase mutations are rare, but we found other forms which were more common in our country. And why does this make a difference? Because the pharmacotherapy for MODY 1 and 3 includes glibenclamide, sulfonylureas, and particularly glibenclamide. MODY 12 and 13 also respond to sulfonylureas, but the dosage you need to give for MODY, the KCNJ mutation, is much higher. Huge dose of sulfonylureas, up to about 40 or 50 milligrams of glibenclamide per day, or maybe even more as well. These forms don't respond too well to sulfonylureas. Some of them actually are obese, can do well with metformin, and some need insulin at an early phase. So phenotypic differences are there. So understanding the condition actually helps in determining the kind of treatment. If you look at the WHO classification, they certainly have broken down the monogenic beta cell forms. And instead of the 14, they have actually cut down the numbers which are more common. And we have seen all of this in our own population. And I'm going to talk about this very interesting condition as well. But we have seen all these conditions, including mitochondrial mutations, which I'm not going to be talking in great detail, but that's another story by itself, wherein they can also come with pancreatitis, they can come with deafness. The phenotypic differences in families can be very vast and varied. We also looked at young ladies with BMIs of 21 who came with diabetes in pregnancy in the first trimester. And we asked, why should such a slim lady have gestational or pre-gestational diabetes? And we found, interestingly, that it's a referral bias in our population in a tertiary care clinic. With insulin requiring young diabetics with pre-diabetes, 15% of them had a monogenic mutation. And this is important because some of these women after delivery may in fact do well with the sulfonylurea. GCK or glucokinase with diet, these can do well with the sulfonylurea. And the others, of course, depending metformin, or some may even require insulin therapy in addition. So this is the profile of some of our lean women who were pregnant who had diabetes. I must tell you that one of the most important things in helping in diagnosis is drawing a very good pedigree chart. Now, of course, being part of a medical college and having students and researchers with me, to draw an elaborate pedigree chart like this was done by one of my own research officers, but it really helps in trying to help you look at the autosomal dominant pattern of inheritance in this particular little girl who had a fasting hypoglycemia and had a glucokinase mutation. And this other lady over here, the pedigree chart, and she had renal cysts and she had a MODY 5 mutation. So the kinds of maturity onset diabetes in the young are different in India, and I'm certain that this condition does exist in East Africa. You will have autosomal dominant young people who have this problem. You should be looking for it and perhaps at some time do a study on this particular condition. Look at the sulfonylurea response, which may be differential. Doses, very low dose sulfonylurea in MODY 3, standard dosing in MODY 1, and particularly in KCNJ mutations, MODY 13, you need big doses of glibenclamide. Even in they come as neonates in some people and in adults in some. The neonates need huge doses of sulfonylurea of 2.5 milligram per kg per day. The young diabetics who come in the first year of life with diabetes. So when you see an atrophic pancreas, it need not be just fibrocalcinosis. These are the other conditions which can have mutations and can lead to young onset diabetes, and the treatment can be very different. Of course, we were thinking that cystic fibrosis is not there in India. Well, it is. It is seen. And so some young patients may have cystic fibrosis. These are variants of fibrocalcific pancreatic diabetes. This is a MODY form, and I won't go into great detail, but each of them has their own subtle different clinical presentations. And mitochondrial disease, of course, is a huge ballgame where you have some family members having epilepsy, somebody else having myopathy. FSGS can actually be a presentation in some patients with mitochondrial disease as well, and diabetes being another presentation. 38-year-old lady diagnosed with diabetes at the age of 19 years, presented with hypoosmolar symptoms, diagnosed to have diabetes. On examination was lean and had a marked reduction in subcutaneous fat. Prominent veins were present on the limbs, and the fundoscopy showed diabetic retinopathy. So you can see this lack of subcutaneous fat and very prominent veins on the limbs, indicating this is called phlebomegaly that you have over here. So what you can see, what she had quite prominently was the high triglyceride levels, and she also had proteinuria in addition, early onset of a glomerulopathy in addition. And this is a feature of obviously having a problem in terms of insulin resistance and a high triglyceride level in addition. So she has what is called a lipodystrophy. And how do we make confirm the diagnosis? The device which we use for diagnosing osteoporosis, the DEXA scan, can be used, and we measure the percentage of body fat in the body. And what you can see over here, there's a lack of fat in most of the body, but in the area of the head, the percentage of body fat is higher. So this is called a partial lipodystrophy, wherein they are grossly insulin resistant. So we did the NGS and we found that there was a particular mutation. This was a laminin mutation causing partial lipodystrophy. Here is another patient with stunting, short stature, lack of subcutaneous fat with severe insulin resistance. And you can see the CT of the abdomen showing almost no fat over there. And this is a complete lipodystrophy, much more severe disease. They need insulin. The partial lipodystrophies, even though they need huge dose of insulin of 120, 130 units per day, or maybe even more, when you add a small dose of pioglitazone, about 50% of them actually have a rapid drop in insulin. The doses of insulin when you give them are not like type 1. They're huge doses. They don't develop ketoacidosis. And by the way, neither do FCPD, neither do fibrocalcific pancreatic diabetes. They don't develop ketoacidosis. So here the insulin requirements are massive. Adding pioglitazone may help. And they have other features like dysmorphic features and other features of insulin resistance. The women have early onset polycystic ovarian syndrome, and they also have a fatty liver, and they can get cirrhosis before the age of 30. So this is another genetic condition which is usually autosomal recessive, less common than the beta cell monogenic defects that you see. Lipodystrophy can also occur in HIV, and this is a postgraduate thesis of one of my PGs. She's now Prof Asha. About 10 years back, we did this, looked at lipodystrophy in HIV, and we found that lipodystrophy and insulin resistance was there. When they were started on heart, they were more prone for insulin resistance and lipodystrophy as well. So this is another condition which you should look at in your population, because they may be more prone for the metabolic syndrome and diabetes at early age. We'll go on to the next patient. 20-year-old gentleman with osmotic symptoms at 4 years of age was started on basal bolus insulin, frequent urination with dribbling of urine and bedwetting, and managed as type 1 diabetes initially. What you can see over here is that grossly uncontrolled sugars when the patient came to us. What you can also see is that this borderline high sodium, and that gave us clue, normal pancreas, and GADs were negative, indicating it's not an autoimmune diabetes. P-peptides were low, indicating beta cell dysfunction. But when we saw this, we thought, let's look at the urine osmolality, and it was low, indicating that this patient also had a diabetes insipidus. So you have diabetes mellitus, and you have diabetes insipidus. What does this patient have? Now, the sister came with a different phenotype, loss of vision till blind, very early in life, insulin requiring diabetes, recurrent seizures, deafness, and finally passed away at the age of 26 years. So essentially, what you're dealing with over here is a syndromic condition, which runs in families. It's inherited. What are you looking for? So we did a genetic screening. The initial MODI panel was negative. We extended on. We now have a 62 gene panel, which we do routinely. And once we did the initial add-on of 17 genes, we had a Wolfram syndrome mutation. Remember, this is called DID mode, diabetes mellitus, diabetes insipidus, optic atrophy, deafness, and you can get other neurological features, developmental delay, etc. That's the classical syndrome. But there is now, we know that it's a Wolfram's-like syndrome, WFS1, wherein they need not have the overt Wolfram syndrome at the same time. And this is certainly a very important differential diagnosis of type 1 diabetes, especially when you have other family members with other problems at the same time. This was published recently in the Journal of Clinical Endocrinology and Metabolism, our series on Wolfram syndrome, showing the differences in phenotype. An occasional patient not requiring insulin, but of course, generally they required insulin. But many of them did not have the classical syndromic presentation of Wolfram's in addition. When you think of Wolfram's, these are the various presentations, but there are phenotypes who may have only one presentation. Now, this patient presented with bladder autonomic dysfunction along with diabetes, and very early. So the autonomic dysfunction was due to the Wolfram syndrome and not due to uncontrolled diabetes. So we should think of the Wolfram's-like syndrome disorders, which may be milder in their presentation, as opposed to the more severe presentations which can happen and which are classical. You should think about these, and they get mixed up with type 1 diabetes. Why is it important to make a difference in diagnosis? Because the non-diabetic presentations can respond to other medications. The endoplasmic reticulum's calcium stabilizers like dantrolene sodium, valproate, and chemical chaperones can be used for treating and delaying the neurological consequences of the disease. There's another disorder. Once again, I'm coming back to the mitochondrial disorder, which I'm not talking about here. If you make a diagnosis, you can use the mitochondrial cocktails, which are cheap and can be used for those youngsters who have that kind of diabetes. Finally, I'm going to come to the protein deficient diabetes mellitus, which we should be thinking about. Described in the 1950s and 60s in India and other countries of the world. Severe diabetes, it was called, because the fasting glucose levels are very high. Age before 30 years, but generally more than 15 years of age. BMI less than 18. Absence of ketoacidosis. Poor socioeconomic status. Requirement of insulin more than 2 units per kg per day. Rural origin. And of course, rule out other causes of autoimmune diabetes and pancreatic diabetes. So here is a patient. And mind you, it's not as common as it used to be in my part of the country, in Tamil Nadu, in India, as it was, but we do get patients like this. So we tried to figure out what the cause is. We did extensive physiological studies. This is my collaborator, Dr. Meredith Hawkins, you can see over here, who's from the Albert Einstein in New York, and she said she'd seen a fair number of these patients in Uganda during her travels over there. So we thought we'd look at this in a systematic fashion, because we have the disease and we also have the facilities at Vellore to actually look at this. We ruled out autoimmune disease. We did an MRI of the abdomen. We characterized the pancreas as normal looking. C-peptide levels were low. And we ruled out genetic causes in terms of lipodystrophy and monogenic causes as well. Then we did these extensive physiological studies. We did the hyperinsulinic euglycemic clamp studies. We have trained our nurses to do these studies. And very laborious, as you can see, taking many hours to look at the peripheral insulin sensitivity. They're called clamps because you keep the glucose levels at 90 milligram per deciliter, infusing glucose and insulin for duration of 6 hours. We did energy expenditure using indirect calorimetry and NMR spectroscopy to look at the micro quantities of fat in the liver and muscle. Very simply speaking, we found that they did have insulin deficiency, but not as severe as the red line over here, that is type 1 diabetes. So they have deficiency, but not that profound, not as profound. And here you can see the type 2s, which have a hypersecretion in the early phase, resistant phase. The glucose levels, of course, you can see the pattern over here. So they are insulin deficient individuals. They are not primarily insulin So hepatic glucose output measured by deuterated glucose. You know, type 2 diabetes is dependent on peripheral resistance and increased hepatic glucose output. The hepatic glucose output over here was lower than type 2, much lower than type 2. Actually, there's no overlap, but slightly higher than type 1 diabetes. So some reduction in hepatic glucose output, but very different from type 2 diabetes. So it is not lean type 2. In fact, even physicians in India call it lean type 2. It is not lean type 2. It's a different phenotype altogether. What was really interesting is even though they are lean, 50% of them respond to oral anti-diabetic agents. So if you've ruled out type 1 and you've ruled out hypercalcic pancreatic diabetes in your population, and this is not a genetic disorder, they don't generally run in families. You've ruled out all that and you think this is the condition. Remember that half of them can actually respond to oral anti-diabetic agents. Now, which ones I'm not going to be telling you because we're trying to figure out by looking at more cases as to what oral anti-diabetic agents they respond to. And of course, 50% of them do require insulin in addition. Now, this is an important thing, a public health thing, which in countries like, well, India, Africa, African countries where resources are poor, in rural areas, we can actually try out oral anti-diabetic agents rather than putting all thin people on insulin. Of course, rule out type 1 diabetes first. The nutritional profile showed deficiencies in terms of their intake, many analytes, carotene, calcium, as you can see over here. Their carbohydrate, this interesting thing is that even when they were put into an environment where they could eat well, they did not like taking proteins. They had an aversion for proteins. And this is something parallel to what we found in our low birth weight studies, which I will talk about a little later. Significant protein intake reduction, micronutrients were lower, and a high carbohydrate intake was present. We looked at the incretin axis, and this is really unique because this is yet to be published, but I'm sharing this with you. We look at the L cell functions in the intestine, and normally in early type 2, the glucagon levels will rise. What we also found very interestingly is that the GIP levels in this lean group, as opposed to the controls, were very low. And the GLP-1, indicating that the L cells and the K cells in the intestine are actually not producing incretins, very low. Is this part of the pathogenesis? Or is it part of a coincidence which is occurring? We don't know that, but it is happening. And this does not happen in any form of diabetes, type 1 or type 2, any other kind of diabetes we know of. In fibrocalcic pancreatic diabetes, and that's another story, the incretin levels are high, indicating that perhaps the L cells are overproducing those incretins. But in this kind of malnutrition modulator, they're extremely low. Now, this goes back, just think, if you have severe malnutrition, if you have kwashiorkor, what happens to them is the gut, the intestine, the villi atrophy. And of course, you start feeding them later on and they recover. Perhaps they are better. But perhaps the enteroendocrine cells do not develop after the initial insult with malnutrition. That's a hypothesis. Can't prove it now, but I can tell you. Now, therefore, we have characterized the physiology of this condition. We think it still exists and it should get back on the WHO classification, which was taken off in the 1990s. Only thing, we think it's slightly different what our colleagues thought about 40 or 50 years ago. They did not have very severe diabetes. They did not need insulin. But the other characteristics, absence of ketosis, lean body mass, age less than 30 years of onset, rural origin, is all true. Now, undernutrition, even in a country like India, and of course, most of us would not like to talk about, we would like to talk about how good or how well our countries are developing, but we need to face certain facts. And even in India, we have about 15 to 25% of undernutrition. In East Africa, we do have a proportion of undernutrition. India has the highest proportion of low birth weight in the world. This may be partly genetic, but it is also due to undernutrition. So is the low BMI diabetes in India, is it due to low birth weight? This is called the Baca hypothesis. If you're born low birth weight, your risk of developing the metabolic syndrome, diabetes, hypertension, and obesity, it's called a thrifty phenotype, and it makes you more prone. And my good friend, Professor Yagnik from Pune, has done a lot of work on this, on cohorts and shown that it's actually true. But we have actually characterized this from a physiological perspective. And in our collaboration with the Copenhagen University with my good friend, Professor Ib and Dr. Alan Wong, we did hyperinsulinic euglycemic clamps and direct calorimetry in normal versus low birth weight individuals. And we found that they were shorter and lighter, had a reduced muscle mass and elevated diastolic blood pressure. And the percentage of body fat was actually quite high, even when they were lean, even when they had BMIs less than 19.5 in rural areas. They were born low birth weight. They had increased body fat in spite of not having insulin resistance at that point of time. We did NMR spectroscopy in them, and we found that the amount of fat in the liver was also quite low. So what I'm telling you here is that there may be a low birth weight factor, but there's also postnatal malnutrition in addition. And animal studies have shown that in severe malnutrition, the stimulants for the beta cells are not there. And I've also shown you that perhaps the intestine villi also atrophied. So you have an initial phase of hyperinsulinemia, and then the beta cells start burning out. These are studies done way back in the 1940s in Kwashiorkor, and more recently in the 1970s, where people have done histological and electron microscopic studies of the islet cells. And what has been found that the normal macro islets are less, and we have more micro islets in malnourished individuals. And of course, this has been replicated in animal studies in rats. Perhaps this is what is happening in human beings. And going back to my initial little verse, they say it's genes, not the blue variety. Environments have a role, and lack of satiety, epigenetics, low birth weight, problems for poor, dwindling secretion and resistance for sure. I actually wrote this poem about 7 or 8 years ago, but it's become a bit of a prophetic statement when we look at the evolution of malnutrition modulated diabetes. So when you have a patient with young onset diabetes, let's get to the basics. You need a detailed history. Going back to even trying to find out what was their birth weight. Draw a good pedigree chart to find out if there are any, even if vertically you can't pick up on the pedigree, you can pick it up laterally from cousins or uncles and aunties. Is it inherited? Maternal inheritance in mitochondrial disease. Is it autosomal dominant, autosomal recessive? The pedigree chart is very useful. Do a good physical examination. Look for subtle deafness. Look for other symptoms in the history like bladder neuropathy, developmental delay. Basic test C-peptide levels, try and do it if possible. GAD antibodies would be the next. And imaging, at least an ultrasound if it's possible. And of course, the other tests are more advanced. Even in India, we are one of the few centers, maybe one of two centers which are doing this routinely. But this is how you actually validate genetic disease. So the basic tests which can be done at least in a secondary care center should be done. So I'm just summarizing here. In type 1 diabetes, lean, low BMI, and they have antibody positivity. C-peptide levels are low. In type 2 diabetes, in early type 2, overweight, elevated C-peptide. Young type 2s can happen. We see it in our population now, but they tend to be more than 10 years of age. In maturity onset diabetes, well, they could be very young, like in neonatal forms, could present, but can present much later on. Low intermediate C-peptide levels, which rise with a sulfonylurea challenge in some types. KPD, I'm not talking about it here because they usually tend to be a little obese. Partial lipodystrophy, elevated C-peptides, complete lipodystrophy, elevated C-peptides. Huge insulin requirements. Some of them respond to pioglitazone. And then you have fibrocalcic pancreatic diabetes with lean, low C-peptides, no ketoacidosis, but ultrasound is positive, and protein deficient diabetes or malnutrition modulated, lean, low C-peptides. All your other tests are negative, and 50% respond to oral antidiabetic agents. Summarizing, the causes for lean diabetes besides type 1, think about fibrocalcic pancreatic diabetes, think about beta cell inherited forms, Wolfram syndrome. Lipodystrophy is rare. HIV lipodystrophy is not that common in India, but perhaps in Africa, maybe, I don't know. You have to see whether it is more common. And protein deficient malnutrition modulated diabetes. Thank you for your patient listening. I'd like to thank all the colleagues I've worked with, innumerable scientists in our endocrine genetic lab who do a wonderful job, technical staff who do a lot of the clamp studies, and my co-consultants and people are not on the slide, the hardworking residents and registrars in our department. Thank you for your patient listening. I'm happy to answer any questions.
Wow, thank you. Thank you very much, Professor Nihal. It was excellent presentation. We really appreciate it. And I think we have learned a lot from your presentation. I've seen a lot of colleagues from Uganda who are experts in diabetes, Dr. Davis, Jaivira, and others. Dr. Amar, would you like to take the second part for questions and answers?
Yes, Dr. Makobe, thank you very much. And thank you, Professor Nihal. This was a very perspective-changing presentation, very insightful. And it will really change the way we look into every patient who walks into the clinic. I mean, most of us do practice adult medicine, so we won't be seeing as many young patients. However, when we do, this is really going to change, how we manage these patients and how we diagnose these patients. As far as genetic studies are concerned, over the years, it's still a newer concept to us, but mostly reserved for research purposes as we speak. The challenge with C-peptide and GID antibodies, again, is they are very expensive tests in our part of the world. And whenever a young patient would walk in, the straightforward diagnosis for us would be type 1 diabetes. So we personally, I don't recall ever asking for any radiology for a young diabetes patient as far as screening the pancreas or anything is concerned. However, this is something that we could really change about our practice on this side of the world. We would invite any members to raise their hands so we could give them a permission to speak and ask Professor Nihal their questions directly. I see Dr. Alfred has raised his hand, so I'm just going to allow you to talk. Dr. Alfred, please unmute yourself and please proceed with your question. Dr. Alfred?
So because you mentioned about, Amar, we mentioned about your adult physicians. I'm also an adult endocrinologist. I generally don't look at anything below the age of 10, and most of my patients are above the age of 15. But the issue here is many patients are undiagnosed or underdiagnosed before they come to us. There are even 35-year-olds who are receiving massive dose of insulin, and you go back into the history, and then you get this pedigree chart, which shows a very clear autosomal dominant. And the poor chap has been receiving insulin for 20 years, and no one's tried him out on a sulfonylurea. He's never had ketoacidosis. He's not lean. In fact, he may be having a BMI which is around 23. So I actually started patients on glibenclamide, and it works wonderfully. Thankfully, that's one of the cheap medications. I'm always worried that the industry might phase out the medication because it's become so cheap. But glibenclamide works, in fact, in MODY, and this is actually more anecdotal, and I'm actually looking at the profile, works better than glimepiride or gliclazide in MODY. And I don't know what that property is, that a sulfonylurea of that type seems to work better than the newer sulfonylureas for treating monogenic diabetes. But many of them are underdiagnosed even when they come to you as adult physicians. Some of them may, in fact, come with complications. Like, for example, I told you about proteinuria and FSGS being more common in lipodystrophy. And even in mitochondrial disease, certain forms of glomerulopathies are more common and come early in the disease. You can get someone who comes like in pregnancy with seizures, and you think it's eclampsia, and the patient has proteinuria. And you notice that the patient also has diabetes. And this may very well be something else. So you need to kind of think a little laterally, think more broadly in your differential diagnosis in these patients.
While we wait for the questions to roll in, I'm personally very pleased that you discussed HIV, in such cases, because this is what we see in this part of the world very often. And the amount of resistance we see for these patients is actually, we are giving them horrendous amounts of insulin. I would probably have a 38-year-old come in who's probably been diagnosed with HIV and diabetes for over 10 years ago. And we would be giving her, like a Mixtard or a Bioslin that is about, 40 units in the evening and, 40 units at night, and with the soluble insulin in the afternoon. She would be taking about 100 units or more per day and yet we could not be, doing very well as far as giving her that kind of control that we would aim for, despite giving the sensitizers and whatnot. So in your clinics, if such a patient would walk in, if you see that, probably a 40, 50 kilo lady in her 30s requires on HIV therapy, on heart, requiring high doses of insulin, how would you go about managing such a case in a practical scenario if you had the test that we had?
Yeah. So I would actually try them out on bioglitazone and see whether it responds. That would be my gut feeling, because I've shown you quite clearly that at least in the early phase, the home IR is elevated, the percentage body fat, differential percentage of body fat is increased. So a trial of, I haven't done a study on this because a lot of these patients are handled particularly by the infectious disease physicians and not us. But I've actually told them, why not give pioglitazone and try it out as well. And, obviously the issues with taking insulin in this particular group of patients there are huge issues, obviously. I mean, I think there'll be compliance issues and, obviously psychosocial issues wherein many of them may not even want to take. And when you talk about insulin, I remember my teacher used to say, love without marriage, horse without carriage, insulin without glucometer. And how many of your patients will monitor their sugars adequately? It's going to be a problem. So give pioglitazone, try it out and see whether they respond. Even, for example, if their weight is stable, why can't you try out low-dose metformin? If their weight is stable, there's always this fixation that if they're lean, if their BMIs are, say, like, 19, 20, 21, and they're staying like that for many years, try out metformin, and as long as they don't lose weight, there's no harm in trying out nodal antidiabetic. So the bias toward insulin, using only insulin should go. You should try and add on OADs, see if they work, and then try to taper off the insulin.
And on the flip side, we actually see that patients start gaining weight on insulin once initiated, and that would be their biggest concern at that point in time. The doctor, we're gaining weight every time, and if you explain to them that it's insulin's doing that because it acts like basically a growth hormone in your body.
Absolutely. So add on metformin. So those are the patients who need metformin as well.
Dr. Alfred has been trying to ask a question. We have allowed you to talk, Dr. Alfred. If you could just unmute yourself. I've seen you raise your hand twice. I don't know if there's something where, as hosts, you need to enable. There you are, Dr. Alfred. Welcome.
Yes, Dr. Alfred.
Thank you. Thank you for a good presentation. Just was curious about the malnutrition and the diabetes. So if you correct the protein, the malnutrition with the protein and everything, is it possible to reverse?
Very good question. Absolutely fantastic question. No. You took the words out of my mouth. So the question is, yeah, you're absolutely right. So, let's look at even type 2 diabetes for that matter. There's of course a very large study which you might have seen published in 2020, which was done by Dr. Mohan and involved multiple centers across the world, looking at rice ingestion and the relationship to type 2 diabetes. I'm saying type 2 diabetes is a different type from this, but there may be some truth in that. One of the things in South India is that the intake of protein in diet is very low comparatively, and generally in India compared to the West is much lower. So by giving protein, would you improve beta cell function? That's exactly what you're saying. And the answer is maybe. We have to do control studies to look and see by giving in an increased dietary protein, can we improve beta cell function? The next question is, what kind of protein can you give? And secondly, if they are from a poor socioeconomic group, you need to find adequate protein substitutes which are going to have good bioavailability to stimulate the beta cells. So obviously, nothing will beat the ingestion of, say, animal proteins, but through various things like gram and lentils, which may have to be taken in higher quantity, and certain forms of millets, you can try and improve dietary protein intake. Now, this is theoretical right now. We haven't proven this practically, but maybe it might help. So that's a very good thought. And in fact, as researchers, we have been thinking along the same lines that perhaps we need to do provocative studies under controlled settings to see whether protein intake can improve diabetes in these patients? Good question. Thank you.
Dr. Lloyd, would you like to say something?
Yeah, Nihal, thanks for the wonderful session. It was very illuminating. The whole spectrum of lean diabetes, which is actually quite new to me, to be honest. What about the incidence of kidney disease in these patients? I mean, you highlighted the 6 different varieties. Now, the hyperglycemia and the onset of does it sort of uniformly affect them, or is there a variability in terms of phenotypic presentations or any environmental factors or their etiologies make an impact kidney disease in them? Of course, not those that have calculi, but otherwise, the metabolic abnormalities.
So, I mean, okay, fine. I've already highlighted the fact that certain forms of majority onset diabetes like MODY5, mitochondrial disease in some patients, and even Wolfram syndrome are much more prone for renal damage through various different mechanisms. But when you talk about malnutrition modulation diabetes, I can only tell you anecdotally, and we're actually trying to collect data as far as longitudinal effect of the diabetes and its complications are there. Is it more? Is it less? I can't give you the answer right now. I would rather wait till I get my data collation right and give you the appropriate answer. I would say it's not a great deal more, despite the fact that many of them have been actually poorly controlled for many years due to their socioeconomic status and not accessing the appropriate treatment. It's not a great deal more. Now, whether it is less is the question. I mean, for example, if you look at the new cluster classification of type 2 diabetes, which those of you who are involved actively in diabetes, they have divided type 2 into different categories now. The mild age-related form of diabetes, people who have mild beta cell dysfunction above the age of 60 or 65. And then you have this form where people are quite obese, but the diabetes is mild. And then you have a severe insulin deficient form of diabetes, wherein they have more beta cell dysfunction and they are more prone for certain microvascular complications. And an insulin resistant form is more prone for developing proteinuria, the ones who are more grossly insulin, and that's actually a problem in India as well. So these patients are not insulin resistant, and therefore I would like to infer that the risk of developing renal disease may be less, but I can't give you the answer to the question right.
Yes, very interesting, because I think the etiology of kidney disease now could be different in these different pathologies, right? Or various other factors contributing to nephronal loss or nephronal damage in these people, besides just hyperglycemia. Yeah.
But you, of course, you do have
something looking at the whole lean diabetes and the kidney. How you're looking at the kidney?
Well, we could do a lot more. Dr. Lloyd, we could do a lot more. In fact, I'd like to tap your brains for ideas on that aspect. What else could we do from that perspective? We are looking at the GFR, we are looking at the urine microscopy, and of course, we've done imaging of the kidneys as well. But is there more that we could actually do from a simplistic perspective? I'd love to have your inputs on that.
Yes, well, it's wonderful. You all have a huge team, and a lot can be done. And so this is something completely new that I think nobody has looked into. In the nephropathy, is it the same as you find in the regular type 2? Is there a difference in the nephropathy that comes, and what could be the possible etiology here? Is very interesting. But it's a remarkable spectrum that you've shown us. Wonderful. Thank you very much. This wonderful session.
So we have a comment from Dr. Mazhar Amir Ali. He's a nephrologist from Tanzania, and he's thanking you first for an insightful presentation and his awareness about the type of diabetes that existed. I think most of us are guilty of this, and he is requesting if you could share, some of your contact details if any one of us attending this presentation would like to approach you with any challenging cases that we have.
Most welcome. I think my email is, I can send you my email right away. And Lloyd also has all my contact details. So you're most welcome to mail me any time you'd like. Quite happy to help you. And of course, work together with you at some point of time to kind of, because I think, particularly malnutrition modulated diabetes, there may be a lot of this out there, and we need to try and figure it out much better. In fact, as I was mentioning, as the socioeconomic status of a particular region improves, it starts coming down. And in Tamil Nadu, we had to actually look around for it. It's not that common in the state where I am in India. But there are states in other parts of India which have a lower GDP in rural areas. And my own colleagues who work in mission hospitals in those parts of the country in India actually see a lot more than I do.
We would invite more questions if there are any. Dr. Lloyd, your hand's raised.
One more thing, Nihal. Now, you see, when you compare the West against us, most of these guidelines are made in the West. Now, in terms of obesity, so you say more than 30, you call them obese. But now, in the Asian context or in the African context, would you apply the same rules or criteria? Or do you think there should be a difference in all this classifications or criteria that we actually adopt to our patients?
So in South Asia, that's in India, we have a different cutoff. We already have a different cutoff. For us, when we say overweight, we say BMI more than 23. Of course,
26.
Yeah, but of course, I think that may be also a generalization. India itself is pretty diverse. There's a very big difference between the state where I'm in, Tamil Nadu, and say Kashmir, which is up in the north. There's a huge difference. But yes, we have a shift to the left and our BMIs are lower. Now, when you talk about Africa, I don't know what you should be saying, because even Africa, you have several ethnic groups. And obviously, there may be differences. You may have to categorize things differently according to whether it's Ethiopia or Nigeria or Tanzania. I mean, my knowledge of the ethnicity there is far more empirical, but you know a lot about it. And I'm sure you should be, I think you should be looking at that aspect. It may involve not very big studies, but taking from different regions, different ethnic groups in Africa, looking at their body composition, and then measuring a little bit of C-peptide insulin. It's not too expeditious. How common are DEXA scans in Africa? Do you have access in Dar es Salaam, for example, to DEXA scans in Nairobi?
No.
You don't?
I guess Aga Khan may have a DEXA. I'm not sure. Nairobi also, I think one, maybe Aga Khan would have, otherwise I'm not sure.
But
maybe more than one.
The best thing to do, if you can get a group of different ethnic groups and try and compare them, it would be wonderful. The other thing which you can do out is the bioimpedance device, which is not as expensive. So you can get bioimpedance, but there are limitations with that device. There's nothing like a DEXA. So if you have DEXA, you can do it, but bioimpedance is the next best thing, and you should answer these questions. I'm sure there are certain ethnic groups where they'd be more conformant with the Caucasian thing, with high BMIs, and others with low BMIs. I'm quite certain that Africa is very diverse.
True.
So apparently one hospital here does have a DEXA scan locally in Dar es Salaam. Dr. Mazhar has just responded.
So automatically the body composition can be measured with a DEXA scan. Generally most of the current versions can measure.
No, how practical would it be to start screening earlier in life? Probably doing a GAD antibody done as part of the routine pediatric examination. No,
it's not worth it. Definitely not worth it. I mean, that's purely research, not worth it at all. Because, for example, I mean, that prevalence numbers would be really low. So we do know that there are type 1s which do run in families. That is true. And autoimmune type 1 can run in families. But doing it as a general population screening, I wouldn't do it. I mean, certainly even in the West, I know there are studies which are actually thinking about doing that as a routine screening, but I don't think it's worth it at all.
So if there are no more questions, we are 10 past the hour, and it's quite late in India, we understand. So Dr. Lloyd, I would request you to close the session, please.
I think, it is a wonderful session, Nihal. Such a lot of work that you all do. That is, it is mind-boggling. and the depth is not just the quantum of work, but the depth of work and the quality of work. I mean, and that itself is a learning from the whole presentation, and the way in which you look into these patients and you've subdivided them and the various categories, and then their phenotypic presentations, the genotypic presentations is phenomenal. It's very, very interesting, and the whole department that you've built up is phenomenal. From looking back to those old days and now, is phenomenal. So I think it's, thank you very much, Nihal. I think maybe we should work together in some way. We'll have to think on that and maybe sit and over a coffee and, discuss. There are a lot of youngsters like Nihal and, people like that out here. Dr. Alfred, these are all people who bring Dr. Mazhar Ahmad, all these people, are very eager to do these things and in different areas as well. So many people I don't mention. So I think a lot can be done, and I really look forward to all this coming up in the future.
Lloyd, I just probably like to say one thing, because you did mention that how things have come about over the last 30 years. And, I always think that any developing system can evolve. It just needs time, patience, and working with the right people. And I'm certain that countries like yours in East Africa, Uganda, wherever you are, I'm certain that one day you will achieve a certain level where you can do these things. It's just a matter of time, patience, and planning, and of course, collaborating. I've also gained a lot by working with people inside India and also outside India. And that also helps a lot. But
yeah,
there are a lot of disappointments along the way. I can tell you that, plenty. But it's building things one by one, and just forgetting about the negative things which occasionally happen on the road. Thank you, Lloyd, and it's been wonderful talking.
Thank you, Nihal. Thanks very, very much. Wonderful session.
Bye. Thank you so much. Good night.